All right, let's jump right into this explainer. Today, we're looking at something that is frankly mind-boggling. We're going to see how a microscopic flap of tissue in a developing fetus can cause absolutely catastrophic, life-threatening damage to multiple organs. It's a condition known as posterior urethral valve, or PUE. And to really grasp the sheer scale of the damage it can cause, you have to think of it not just as a medical anomaly, but as a terrifying high-pressure plumbing nightmare that starts happening before a child is even born.
To make sense of all this dense clinical info, we're going to follow a clear roadmap today. We'll start with what PUV actually is, tackle the massive pressure problem it creates, learn how doctors spot the signs, explore the high-stakes treatment and surgery, and then wrap up with what life looks like after PUV.
Okay, part one. What is PUV? Let's get our bearings and define exactly what we're dealing with.
So PUV is exclusively a disorder in boys, and the gravity of this, it's huge. It's literally the most common malformation causing bladder outlet obstruction in male children. But even more alarming, it is the #1 culprit behind pediatric end-stage renal disease and kidney transplants. It's just this tiny physical barrier, but man, it carries monumental, life-altering consequences.
Now, you might be wondering how often this actually happens. Well, it's relatively rare, striking somewhere between 1 in 8,000 to 25,000 live male births. But the downstream effects are incredibly severe. This obstruction begins remarkably early, too, typically becoming a real issue around the 8-week mark of fetal life, right when the posterior urethra is developing.
So what does this blockage actually look like? Doctors categorize it using something called the Young classification. A massive 95% of cases fall into type I. These are tiny flap or valve-like protrusions of mucosa that originate in the urethra. And they act exactly like a one-way valve, so urine from the bladder gets trapped behind them, yet a catheter pushed from the outside could easily slide right past them. While there are type 2 and type 3 variations, with type 3 being this rigid windsock-like ring obstruction, type I is overwhelmingly the primary villain in this story.
Moving on to part 2, the pressure problem. This is where things get really intense. Think of a blocked drainage pipe in your house. The water has nowhere to go, right? So the back pressure builds up sequentially in a massive domino effect. First, the urethra gets blocked by that tiny valve. Then, the bladder walls undergo massive hypertrophy. They actually thicken and lay down fibrous tissue, trying to forcefully push the fluid out. Next, that high pressure forces urine backwards, causing the ureters to swell up significantly. Then, the kidneys are quite literally crushed from the inside by this unyielding pressure. And finally, and this is wild, because the fetal kidneys aren't releasing urine into the womb, the amniotic fluid drops dangerously low. This lack of fluid stunts the baby's lung development, leading to pulmonary hypoplasia. So this plumbing backup essentially damages the entire physiological house. So the big question is, how do different organs handle all that intense pressure? Lung damage can unfortunately be immediately fatal at birth, but looking at the kidneys, we see a stark divide. Some damage, like glomerular insufficiency, is actually reversible. If we fix the plumbing early enough, the kidney function improves. However, if the high pressure has caused dysplastic damage to the actual kidney tissue, that is entirely irreversible. It leaves a permanent level of renal damage that restricts the child's lifelong growth and basically sets them on a path toward permanent renal failure. Now, here is where the body does something incredibly dramatic. In a desperate attempt to save itself, the fetal body will sometimes literally blow a gasket. We call this a pop-off mechanism. One example is VURD syndrome, where the body essentially sacrifices one kidney, allowing massive reflux into it. Or it might even rupture a part of the urinary tract to create urinary ascites in the abdomen. It sounds terrifying, I know, but it's actually the body's natural safety valve. It's deliberately failing in one area to relieve the immense system-wide pressure to hopefully protect the remaining kidney and bladder. Absolutely fascinating, right? All right, part 3, spotting the signs. How do doctors actually act as medical detectives and catch this? Timing here is absolutely everything. Catching PUV early versus late completely alters the game plan. Before birth, typically around the 12-week ultrasound, doctors look for a telltale keyhole shape. It's a grossly distended fetal bladder that funnels down into a dilated posterior urethra, making it look exactly like an old antique keyhole. But if it's missed before birth, the baby will present in severe crisis afterward. We're talking respiratory distress from those underdeveloped lungs, a visibly thin and weak urinary stream, poor urine output, and a general failure to thrive. So what do doctors do if they suspect PUV after the baby is born? They turn to something called a VCUG, or voiding sister urethrogram. This is considered the definitive radiologic study.
By filling the bladder with a contrast dye and watching the baby void under an X-ray, doctors can clearly reveal those thickened bladder walls, the grossly dilated posterior urethra, and, crucially, they can see the exact abrupt transition point where that tiny membrane is actively blocking the flow.
Section 4. Treatment and surgery. Once they know what they're dealing with, the pace completely shifts to life-saving interventions. You can't just rush into a permanent surgical fix right away. First, there's this frantic, incredibly delicate triage process. The baby must immediately be referred to a tertiary care center. Then, doctors have to bypass the blockage. They usually do this with an immediate urethral catheter to drain the backed-up system and instantly relieve all that pressure. At the same time, pediatric nephrologists are working overtime to stabilize the newborn's deeply out-of-whack fluids and electrolytes, while mechanical ventilation is often deployed to help the newborn breathe if their lungs are underdeveloped. Once the baby is finally stable, it's time for surgery. And wow, has medicine advanced here. The traditional approach used to involve invasive open surgeries, like creating a vesicostomy to let urine drain straight out of the abdomen, or blindly destroying the valves with specialized hooks. But today, the modern approach is a masterclass in precision. Surgeons now use microscopic cameras, slender cystoscopes just 6 to 8 French in size, to navigate up the tiny urethra and ablate the valve with lasers or electrocautery. They can perform this highly targeted fix even in premature babies. We're talking about babies that weigh less than a standard bag of flour here. Now, here's a really crucial and maybe slightly surprising preventative step that comes next. Routine circumcision is strongly advised following the initial surgery. Because the urinary tract is so dilated and sluggish, the overall risk of a severe urinary tract infection in a PUV patient is a staggering 50 to 60%. Performing a circumcision dramatically slashes that massive risk by up to 92%. It acts as a vital shield to protect those already vulnerable kidneys from further infectious damage. And that brings us to part 5, life after PUV. Because the laser surgery is definitely not the end of the story. You might think, okay, the valve is destroyed, problem solved, right? Well, not exactly. The bladder itself is often permanently damaged from fighting against all that high pressure in the womb. This creates a condition known as valve bladder syndrome. The bladder wall becomes thicker, less compliant, and highly dysfunctional. And what makes this incredibly challenging is that it changes dynamically over time. In infancy, the bladder is often hyperreflexive and spastic, but by the time the child reaches adolescence, it can become massive, floppy, and completely fail to empty. Because of that permanent damage, the management shifts from a quick surgical fix to a lifelong marathon. Long-term follow-up requires rigorous dedication. The goals are strictly focused on optimizing renal function, constantly monitoring creatinine, and achieving continence without causing further renal scarring. To do this, patients rely heavily on medications like anticholinergics or alpha blockers to regulate the bladder muscle. They have to adhere to strict timed voiding schedules, and some even require overnight indwelling catheters to ensure the bladder stays decompressed while they sleep. This prevents silent, high-pressure damage from happening in the middle of the night. Which brings us to a really profound question to end on. Does intercepting the plumbing nightmare truly fix the patient? The surgery is undeniably a medical marvel, and it effectively saves these babies' lives. But for these young boys, the journey to preserve their kidneys and manage a fundamentally altered bladder isn't completely cured on the operating table. It's a meticulously managed, lifelong battle. Thank you so much for joining me on this incredibly fascinating explainer. Keep exploring, keep questioning, and I'll catch you next time.